Good afternoon, everyone, and welcome. We're going to give everyone a couple more minutes to join for those late additions, and we will get started here shortly. Thank you. Give 1 minute. Get started. Well, it seems like that's about everyone that we had registered. Thank you again, everyone, for joining. My name is Anthony Felipe. I am the director and board member for Florida HFMA South Region Education, and welcome to part 2 of our election series here in cooperation and co-sponsored by our friends at the Florida Sunshine Chapter of AHAM and the South Florida Hospital and Healthcare Association. Just a couple of housekeeping notes before we get started. If everyone would please keep their microphones and cameras off during the panel discussion. However, we will have intermittent breaks in the action to address questions. If you have any questions as we go through, please enter those in the chat, and Kathy and I will moderate those, and I will read those out to the group. And then at the end of the presentation, once we've completed our materials and our topics, we'll open it up to a little bit more of an interactive discussion where we'll encourage you to turn on your cameras and interact directly with our panelists this afternoon rather, excuse me. Quick shout out to our chapter sponsors for Florida HFMA, our annual sponsors, as you can see on the screen here. Without folks like this and their contributions and support to these chapters, we wouldn't be able to accomplish all of the education and networking events that we're putting on, and hopefully soon back in person and back to as much of normal as we can get to. So thanks again to both the Florida HFMA chapter sponsors as well as our friends at the AHAM Florida Sunshine Chapter. If you're a provider and you're on this presentation and you need any services or looking to get to know what else is out there on the market as far as outsourcing and business partners, please check these folks out. They do a lot to make sure that we can make these things happen. So last housekeeping note before we get into this is if you've dialed in via phone and you need your CEU or CPE credits, please make sure that you log in through one of the registration links, whether that is the direct Zoom link or the CVent link, so that we can make sure that we have your information and you get the credit that you deserve. So with that, I am honored to introduce our esteemed moderator and panelists for today's discussion. I will start with our moderator is Kathy Reep. She's a senior manager with PYA. She has more than 3 decades of leadership experience in the healthcare industry. Her hospital setting expertise is in compliance, financial advisory, reimbursement, and managed care. Kathy has helped with Medicare, Medicaid workers' compensation, reimbursement, and many other complex programs and issues. Prior to joining PYA, Kathy served as a vice president of financial services with the Florida Hospital Association. Kathy is also a recipient of the 2019 Bob Broadway Distinguished Service Award from the Florida chapter of the HFMA. Now, our panelists today, starting with Jamie Caldwell, president of the South Florida Hospital and Healthcare Association, and he is currently the president. South Florida Hospital and Healthcare Association is a trade association representing the interests of hospitals and healthcare providers in Southeast Florida. Mr. Caldwell is a member of the American College of Healthcare Executives and the Healthcare Financial Management Association for over 30 years. His healthcare experience includes healthcare regulation with the Florida Department of Health, managing multi-state emergency medical transportation for private national ambulance company, and now healthcare policy and analysis with this association. Next, and our second time with Paul on one of our events, so thanks again, Paul. Paul is the CEO of the Miller Wenhold Capital Strategies and also on the National Legislative Board for AHAM. Paul has vast experience in the lobbying profession, and in January of 2006, he introduced the first lobbying certificate program for the profession. Paul has led the fight to bring about changes to the electronic filing system for lobbying disclosure forms in the House of Representatives, and is also instrumental in shaping the debate on lobbying reform in 2006 and 2007. He has appeared on several news stations and discussed ethics and transparency issues. And finally, our friend Chad Mulvaney, Director for the Healthcare Financial Management Association. Chad is currently the Policy Director for HFMA, and is based out of their Washington, D.C. office. Chad has over 20 years of revenue cycle reimbursement and population health management experience, working both as an internal and external consultant to large healthcare systems. Prior to joining HFMA, he helped Fortune 500 companies re-engineer their innovation and marketing processes as a consultant at the corporate executive board level. Chad is active with the Virginia chapter of HFMA, where he has served as a past board member. No, that was a lot. So I appreciate everybody. And Kathy, thank you so much. Take it away.
Thank you very much, Anthony. I really do appreciate the opportunity to moderate this distinguished panel today. I'm glad that I don't have to answer any of the questions that we're going to be dealing with, because when I sat down earlier this week and kind of drafted out some thoughts, some questions that I wanted to raise with our panelists, who knew that this week would be another pure example of 2020? So we have a lot of things that we want to discuss. We did try and narrow down the topics for today based upon the survey to the membership of the two organizations, just to get an idea as to what things were most important to you. So the first topic that we're going to address today is COVID relief. And so let's do a quick survey to start with. Survey, there have been many changes under the CARES Act with billing and reporting requirements. To what degree has your organization been able to keep up? We have handled successfully and have taken steps to stay up to date. We are struggling with staying up to date on the changes, seeking recommendations. We have been trying to stay up to date, but with limited resources, it has been a challenge or unsure. And I guess if you are in an organization that it is not applicable, then you might want to use unsure as well, because we're not going to count that one. And we'll see the results shortly. Looks like either you have been handled successfully and you're able to stay up to date, or this has been a struggle because of limited resources. So great response, and we appreciate everyone responding to those questions. Again, we know that we are still in a situation where we don't know what will be the ultimate outcome of the 2020 election. But I'm going to kind of go back a little bit. I'm going to go back a week, and hopefully we can remember back that far. But after what we've been dealing with this week, I'm not so sure. So I guess I would say a week ago, we were seeing nearly daily meetings between the representatives from the Trump administration, predominantly Nick Mulvaney and Nancy Pelosi representing the House, to address a new relief package. Again, stalemate on the election. We don't know what we're targeting, but it does look like very likely that we're going to continue to have the Republicans in charge of the Senate. We know that in the Senate, we have this diverse opinion as to how large of a package we can get for relief. So I guess I turn to our panelists in terms of, first of all, what's next for a new relief package? Is it going to happen, and how soon will it happen? And including in that, what do you see included in a package that we might have, and will it be this month? So who wants to kick it off?
I'm happy to go first, I guess.
Aham starts first alphabetically.
I'll try that. That has been one of the sticking points since the last stimulus package was passed in March. There have been a lot of, whether it be hospitals, small businesses, or folks who are just out there unemployed and wanting those benefits. So people have been struggling. The push has been the election, and I think Democrats, held a lot of cards, and we're I think, in a better position prior to the election, with all the polls out there saying that there might have been a clean sweep. And I think the speaker, if I was her, I would have done the same thing, and said, hey, let's wait till after we get the White House, the Senate, and can keep the House. we'll pass our $3 trillion package, which will include a lot of healthcare related items. It will include infrastructure, and it will help workers. Now that doesn't seem like it will play out, I think we're just waiting on the 2 Georgia Senate races. Quite frankly, there will likely, one will be already in a runoff, the other second one likely headed to that way. So I believe, and Mitch McConnell has said this week, that they will try to get a package done before the end of the year. That means they come back next week, and I suspect there will be a real aggressive push to, particularly on the Republican side, to get something done before the new Congress takes over, so that they can give the president, if he does lose, a going away president, so to speak, type of thing. What will include? I do think there will be money. Counties and states are hurting, so there will be some money in there for that. I know Republicans have been a little bit not sure about doing that because of some of the states like New York and some of the other more left-leaning states that they don't like, and some of the things that they've done in the past. There will be some worker relief, and there will be the PPP loans for small businesses. There's money already there, so that will be reinstated so that you can get a second bite at the apple. And there will likely be some hot money for hospitals. The question just becomes how much. I'm not sure that right now that there is going to be a huge push to give a lot more money to hospitals. I think that may come next year, but there will be a little bit for everything. The question just becomes how much. I think we're getting probably closer to the $1.82 trillion max. There's no way it goes over that. Last counter by the White House was 1.8 trillion. I know Majority Leader McConnell said no to that. They are having a hard time selling more than $500 billion in relief. But I think as they look at this now, they may know that they have to give up something to go into 2021, kind of taking control of things.
Thanks, Paul. Others?
I think Paul was pretty succinct in that, and I totally agree with what he said. I don't think we're going to see anything in the lame duck session. I think what they're terming CARES 4.0 might be probably something that comes up in 2021 as opposed to lame duck. And I think the issue is how much, and what the Senate Republicans were thinking was that because business was starting to come back, we were starting to see better gross domestic product numbers, that perhaps we didn't need that large of an incentive versus what the House of Representatives was looking at with their first 3 trillion, then 2.2 trillion. So it's definitely going to be I think a decision based on what's going to happen between now and the end of the year with COVID, as we've seen what's happening up in the north central part of the country, where they are having the kinds of problems that Florida had back in May and June. We might see more emphasis put on a package that's a little bit larger than the 500 million that the Senate was talking about. But we will see something, and the question is going to be how much.
But Jamie, you're saying it will not be until next year. We won't have anything this year.
I don't believe you're going to see anything in the lame duck session.
You know, I think both. I would agree with both points of view. I think I would tend to trend towards Jamie in terms of the timing on it. I think that, you know, assuming that, well, depending on the outcome of the presidential election, you might see the Senate put more emphasis in confirming judges, sort of cleaning house before they leave to sort of lock some of those things in. You know, the other question as to what's going to be included in the package is certainly Majority Leader McConnell has made an emphasis about liability protections for businesses. So whether or not they'll be able to negotiate some of that, and that might be some of the quid pro quo with Speaker Pelosi, is liability protections for some additional funds for states and localities.
If I could just follow up on that, I do take a little bit opposing view than that, because I do think it has to happen in the lame duck, because you look at the Georgia Senate races. If those both go to runoffs, those runoffs will happen in January. If Republicans lose those 2 seats, then you're looking at a 50-50 split, and the Vice President, Kamala Harris, would be that deciding vote, which would give the Democrats the edge that they need to get a closer to $3 trillion package. That's where I believe they will try very hard to get it done during the lame duck.
I guess I would say whoever the vice president is would make that decision. So,
Correct. Correct.
let me ask you a question, because not only are we looking for COVID relief, but we also are running up against the December 11th deadline for continuing resolution to keep the government funded. We have issues that are very, very important to the hospitals that are on the call, such as the Medicaid dish and the issue we've been dealing with since the Affordable Care Act of the $4 billion cut this year, it has been extended and extended, and now the extension goes to December 11th, related to Medicaid disproportionate share funding. Are we going to have some sort of a package? See, I was thinking that maybe we would have something that would address to some degree COVID relief plus the continuing resolution to keep the government open and functioning. How thin of a package or narrow of a package are we going to see for keeping us functioning, keeping us open?
I'm happy to go first too if they want. I do think it's going to be a clean continuing resolution. I do think they'll want to get this into next year. And again, if it is a new administration, they'll want to be able to do some things there. Again, it doesn't make it any easier going into a new administration if we do have a Senate controlled by Republicans, House, it looks like Republicans will pick up maybe close to 10 seats in the House. When all said and done, and you have so they're controlled by Democrats, and then you have a Democratic White House. It's not going to be any easier than it is today. So I do think, like they did this last up to get to the December 11th continuing resolution, I think they'll try to make it clean and get through just into next year and get out of town. They're not going to want to be here very long.
And Paul, let me ask this: do you think they'll do a full year, or do you think they'll punt it into the next year?
I think we're looking at maybe February, March timeframe. It's not going to be a full year. I'd be surprised if they can get it past March, but that typically has been kind of the timeframe when they have punted these things. It's been early March. It's been the March, February timeframes.
And I think that makes sense, just because to get a full year package is probably going to take more horse trading than they have time to do in terms of what they have on their plate.
And I think if you look at from both sides, you have a number of new members coming in. I don't think they're going to be able to sell that to their caucuses to say, hey, we should do a full year, particularly when you have a whole crop of new members coming in and then possibly a new administration. I don't think they're going to want to do that. Neither side has the votes for that, I think.
And I do know that the American Hospital Association is pressing as hard as they can on certainly the Medicaid dish front. They understand what the implications are for that, as well as there are some timing issues with some IT legislation that they're also trying to get pushed off into 2021. So I think in their minds, they're going to try to keep that package as slim as they can so that there is a better chance of getting consensus on both sides of the aisle.
One of the first issues that was addressed, and I guess I want to say CARES 1, was sequestration. And what we had was sequestration went away until December 31st. Well, if we don't have a new CARES package till next year, and we have a very slimmed down continuing resolution, will we be back in that 2% reduction for sequestration come January 1, or will that be extended? Will the cessation of sequestration be extended, or will we be back to that 2% reduction in our payments?
Well, the AHA is trying to include that issue also in its package. So anything where there's a pending significant financial implication, they're trying to kick the can down the road. So I think that they would try to, in a package put forth during the lame duck, try to get that moved into 2021, where we might have a new administration and there might be a different perspective about how we need to move forward.
I would just say, I suspect if they did something, it would be short term. I think they would just want, again, I think they're going to want to get out of here as fast as they can. They'll come back for orientation. They'll come back and decide who their leaders are, their next leaders are, and then they're going to want to get out of here as fast as they can, which means they're going to, I think a lot of that next round of stimulus there are a lot of agreements on it. I think Mr. Mnuchin and Speaker Pelosi they have some sticking points, but I don't think there are that many that I think people are going to realize now that the election's over, we can get this done a lot faster than they did. I think it was all politics leading up to the election, why they didn't get it done.
It was all politics and what they could sell to Leader McConnell.
I think for providers, if we go back with sequestration, that reduction in reimbursement, I think that is a significant issue that they're going to have to deal with. And it's not knowing until the last minute when you start budgeting and looking at your reimbursement going into the new year. I think it is one of those areas of concern for providers. Also, I'm going to just throw this out because there have been so many waivers and so many issues related to how we bill, how we do the things that we do. And it has been a back and forth in terms of CMS on their office hours call saying 1 week, this is the way we want you to do it. And the following week saying, whoops, we misspoke. A lot of this information, unless you have printed out and saved all of those transcripts of the office hours calls or the confusing information, what do you picture for as we move forward into 2021 COVID-related audits? How much of a compliance burden is that going to be on providers?
So Kathy, I think it will be a burden. I think to your point, it's whether it's the waivers from CMS or how you've sort of documented and captured stuff for your CARES Act reporting for the provider relief funding. If you're making a decision based on documentation from CMS, make sure you've got a printed out copy of the FAQs or the transcripts. You've got it in a file. You've got it saved somewhere else as a backup so you can lean on it. Just exactly to your point. I don't know if it's an audit issue in 2021 or if it's an audit issue after the public health emergency, because I would struggle to see CMS sort of sending people out to audit these types of things in the middle of a continuing public health emergency, particularly given some of the spikes that we are starting to see in pockets of the country that are starting to be projected in other parts of the country.
Good point. I'm assuming 2021, but we could be talking much longer than that. Now I just got depressed, Chad. Thank you.
I just add to that with this and the issue of price transparency and things like that. When you're talking about penalties, I think Chad's right. I think there is going to be some leniency shown here that, again, we're still going to have some spikes this winter. And I don't think hospitals have made, I think, a pretty good case that they just don't have the bandwidth to continue to do these things. And the people that they've had to lay off and try to bring them back. And when you have spikes and you're not doing other types of procedures, you're going to have loss of revenue and continue to have that. So I do think there will be, I know we have been talking legislatively about putting off some of these penalties and things like that for 18 months. And we have had pretty good success. And I know AHA has talked about some of these things as well. So I think there will be some leniency, and I think people will look at this and you may have to do it legislatively to say, hey, we're going to push any kind of penalties or audits off for at least another year, 12 months to 16, 18 months.
I think what gets tough with that, Paul, is the audit entities get anxious.
Yep.
And because it's money to them if they are able to audit, and therefore they're anxious to get busy and to do this work.
And the politics will play into this too. I mean, once one side or the other hears from somebody, then it becomes a national crisis, and then we've got to do this and without really knowing the facts. So that is going to be the challenge going forward on a lot of these issues is how do you tell the story and do it effectively so that Congress does not rush to do something that has a lot of unintended consequences.
Absolutely.
And Kathy, just to that exact point, I'm going to say the painfully obvious. So for any of the COVID cases for which you've either gotten Medicare increased payment for, or you've filed and been able to claim a targeted distribution from HHS, from the provider relief funds on, I would just go to bed tonight knowing that at some point somebody's going to come back and audit that, just given the political pressure and scrutiny around those cases. Obviously, if you've got a Republican administration that is, bet the house on it. If you've got a Biden administration, I still think just from a responsibility standpoint, you're going to see, again, scrutiny on those cases.
Yeah, absolutely. It's going to be here. We know that it's on the IG work plan, et cetera. They're coming and they're going to be looking very closely.
And Kathy, hospitals are, I think, really smart when it comes to this. They've learned their lesson over time. Certainly, if they tried to submit a claim to FEMA for reimbursement for damages, they know that every I has to be dotted twice, and that T needs to be crossed with a strong, bold stroke. So they have been very aware that whatever they're doing with respect to the expenditure of those funds, that they need to account for it meticulously. We've had a couple of programs in our association looking specifically at that issue, and it does seem like hospitals are, as best they can, and some are a little constrained because of some personnel issues that they have had during the pandemic. But it does look like they are pretty much on top of it. So I think they're prepared. They know what's coming. In fact, that's what our advice has been to them. It's coming. Get ready for it, because as soon as this is over, you can expect a visit.
Well, and I think the other side of that, Jamie, is the fact that we've got the audits and reviews that are going to be related to the funding that we received, but then we've got the claims. And we've got issues. I'm hearing providers ask questions repeatedly, particularly after the requirement that after September 1, you have a positive COVID test result on your claim, on your record to support getting the additional DRG reimbursement. And you have individuals who are reaching out and saying, my physician has documented COVID. They say list COVID as a diagnosis, but I don't have a positive test result. What do I do? Because we're back in that world of there's a conflict between billing and coding. And it's, you can code it, but you can't bill it. And then our systems have to be able to recognize, yes, this is a code on a claim because it was a diagnosis provided by, or it's a code on a record because it's a diagnosis provided by the physician, but it isn't going to get to my claim because I can't support it. So I think that becomes, are you able to really control what's going out between HIM and billing? And
that's my understanding is in order to bill using that Medicare code, you had to have a positive test. It couldn't just be a diagnosis from a physician without the reinforcing test to go along with it. So,
but coding, that group of people, the coders will code what the physician diagnoses, but you just can't let it pass over to the claim. So I think it becomes this, again, the confusing world of working in a hospital. I would like to ask either Diane or Anthony, let's open it up and see if there are questions related to COVID CARES Act funding, anything like that from the audience.
Hey everyone, so there aren't any questions in the chat. Just a quick reminder to everyone, please feel free to enter your questions in there. Or if there's anyone that would like to kick on their camera and unmute their mic real quick and ask their question, that's cool too.
Hey, Noli, it's Dad.
Hi.
I'd love to just get a little more clarity around this coding issue with respect to the positive test. So is that positive test in the medical records, Kathy? And so does the coder, so how does that translation, or how does that data move from one point to the other so that hospitals recognize or can comply with the specific regulations to receive that additional funding?
Well, you would, in order to get the bump in your DRG reimbursement, and I see people who are here who are much more akin to or familiar with how their systems work in their hospitals, but to get the added reimbursement, the 20% bump in your DRG payment, you would have to have and this is as of September. Remember, this is one of these things where the rules changed. Yep. Early on, this was not a requirement that you have a positive test, but then they decided that as of September, you had to have a positive test. So some way or other, it's not just the physician documenting COVID, it is a test or the results of the test. Let's say, for instance, you had gone to a urgent care center and had been tested. You had a positive test, and then you developed major issues, complications, and were admitted to a hospital. You've got those test results from that other entity that you're going to be able to get onto that medical record. You have to have the positive test results in order to get that increased reimbursement. I see Cheryl sitting there on this little board right next to Noel. And maybe Cheryl, you can even address how it's happening within your hospital if you don't mind me calling on you. Ah, she minds. Oh, well. Anyone else want to jump in and say how they're doing it, how they're handling getting this on the record? We have a quiet group. Okay.
In the chat.
Kathy.
Oh,
you got one. Go ahead.
Anthony, it's Christina. Sorry, I forgot about the chat box. Kathy, this makes me think about the state reporting requirements for a positive COVID test. So I'm wondering if that reporting could be used. Am I making sense there?
You're making sense to me, but again, think about this. How are you getting this on your patient record? Because someone's going to come in and audit your patient record to find out whether or not you have this documented on their claim.
Right. I guess where I was going with that is perhaps I don't know if people are bumping up those reports against the claims and or medical records because of the inconsistencies in the requirements. And what you just mentioned earlier, where there wasn't a requirement to have a positive test, but yet you could put it, put it on the claim. So right. I don't know if some reconciliation between those reports would help. I kind of thinking out loud here.
Well, Cheryl has responded through the chat. She says that we have an edit to catch a claim if there isn't a positive test. And so then they are actually going to go back through. I think that was what it said. I had to read that very quickly. We have an edit to catch a claim if there isn't a SARS test, so we can go find a test.
Correct. I think I'm unmuted now.
Yes, you are. Now you can be called on repeatedly.
So yes, that's what we did. There's really no other way to do it. So if that specific DRG comes up, we validate that there's a positive test, and if not, then we don't send out the claim till we find one.
Got it. Does that help?
Now our hospital is pretty aggressive with testing, so it's not a huge issue for us because we seem to do a lot of testing up front. So in most, if not all cases, we've had a positive test.
What about the person who comes in from the outside who had a positive test on the outside and then they have developed complications and are admitted?
So we haven't had that yet, but I would think we would have to find out where the test was done and then see if we can get the results. And that's, for all these drive-through testing sites, when we were part of that, we did have that information, but it's all private now. So no one has that data. And I don't even know how you would go about being able to gather that data and get it into your record, because the information we get is always de-identified. Now, if you're part of the record exchange, then you can get results from outside of your organization. So if they happen to go to one of those organizations that participate in that, then you can sometimes get that data. But as far as I know of, none of the private entities that are doing all the COVID testing do that.
Interesting. And maybe others will share in the chat what they're doing, but I do appreciate Cheryl and Christina that y'all jumping in. If there is no additional discussion on COVID and CARES Act relief funding, anything like that, I would just say prepare for audits that will be coming to both a business office, a health information management department, and an accounting department near and dear to you within the not too distant future. It's coming. And there will be oh, we do have a question here. Is there any guidance on public emergency overpayments that need to be refunded? We billed for the public emergency funds and then found out the patient had health insurance and billed the health carrier. And once the payment is received, we have a credit under the public emergency health fund. Interesting issue. Has anyone heard or dealt with this? And I don't think, Tanya, this is going to be something unique to your organization. I think this would be something that others are going to experience as well. This is where essentially you build through HRSA.
I think Mr. President had a question. Robert?
I did. It was too long to type in the chat box, so I just thought I'd just go ahead and say it. So it's more related to the provider relief funding, the post-payment requirements, the instructions continue to change. It's not really stated, it's not implicit in the instructions, maybe it's implied. Do you think that providers will be repaying funds back that they've received on the provider relief fund? I know the instructions continue to change, but just want to get your insight on this.
So just to clarify, if you walk through those two steps in the calculation and you don't have COVID-related expenses net of other sources of reimbursement in step one, or if you've gotten more PRF than you have funds that you can sort of account for in steps 1 and 2, which is the COVID-related expenses and the lost revenue attributed for COVID, would you have to refund any PRF overpayment back to HHS? Is that the question?
Right. Or will they rewrite some more instructions to then add some more things like, obviously we're still in the pandemic, right? So we don't have a crystal ball as to what those expenditures are going to be. But, ultimately at the end, you still think, with a phase 3 distribution coming up, and maybe even some more targeted distributions, that there will be ultimate overpayment? Or is this really the insight that HHS really doesn't want any providers to return on this money unless there's just a significant issue related to receiving that funding from a kind of more of a PR standpoint?
So I would anticipate that if at the end of the public health emergency, you have excess PRF based on what you can justify from your COVID-related expenses and your lost revenue, that money would have to go back. Now, your point is well taken about how we don't know how long this is going to be. And right now the instructions say, you report at the end of your calendar year 20, and then you report at the end of June in 2021. So if we sort of have issues through the spring and that sort of looks like it sort of bleeds into the summer, they may extend the amount of time that you can use the funds. So you may have more opportunities to accrue against that PRF payment, but my sense is that they'll be asking for those dollars back. I think the question that I've had is, if they do pull those dollars back, will they do sort of a reappropriation of those dollars back to providers that, didn't receive enough PRF relative to the expenses they incurred or the revenue they lost? That to me is the open question. And I'd be curious on Paul or Jamie, your thoughts.
Chad, I think you're right. I think they're going to extend it because we're not going to see general availability of vaccines until the mid part of 2021. So this is this is going to continue well into 2021. And some hospitals in New York are budgeting for continued impact through 2022 of COVID-19. So I can't imagine that the Congress would want to look like they are getting money back from hospitals that laid it on the line to treat COVID patients, giving up private patients on the way. I think they would do everything in their power to come out looking good. So I can see them extending it well into next year.
I would agree with that. Again, if you look at when people will actually be back to doing in-person meetings around here in Washington, I mean, we're looking at the summer of 2021. Again, you have to look at, we have an older leadership on both sides of the aisle, and they don't want to go and have all these people running through those offices and continue to spread the pandemic, or they get sick. So I think, again, when you're talking about continuing in a virtual world, I don't think they're going to say, hey, we want money back right now. I think there will be extension of dates on everything. And that's why when we talk about the next stimulus package, that's why I believe it will happen in the lame duck, because I do think when you talk about PPP loans and things like that, those all have to start to be repaid starting of January 1st. And so those types of deadlines are going to come, and Congress is not going to say, hey, we're going to be asking for money back or people to repay these things. I think they're going to look for every way to push this into 2021 and at least late 2021 would be my guess.
Thank you. And we did have that question from Tanya related to repayment for an incorrect claim that was submitted to the public emergency funds. And I think that's something that we're going to have to look at and get you an answer for in terms of how to address a credit there. But we'll see what we can find out. It might be a good one for HFMA or AHAM to take. If we've gotten paid for a patient who winds up having insurance after the fact, you've identified them as uninsured, but then you find out later, then what do we do to give the money back? But if there are no other questions on the issue of CARES Act and COVID funding, let's go on to our next polling question. Very simple question for you here. Did you know that the Supreme Court is going to hear a case involving the Affordable Care Act on November 10th? Yes, no, or unsure? And I'm not sure how we get the unsure in there, because either you knew or you didn't know, but no comment.
Just give it another couple of seconds, Kathy, and then we'll broadcast the results.
Sure. Okay, the majority of the people, 52% of the people said that they did not know that there was going to be a hearing on November 10th. Well, get ready, folks, because we do have the Supreme Court, which now has the full 9 justices who will be addressing or listening to a case. It is Texas v. California. Interesting combination. Sounds like the war between the states, but we won't go there. This essentially looks at the whole concept of if the tax has been done away with, and the tax is the one thing that at one point, I believe it was the Chief Justice who said that as long as it was a tax, it was okay. Well, now if the tax has been eliminated, do we have an issue with the ACA continuing? Now, from a provider perspective, we got to look at the Affordable Care Act from 2 different lenses. One, all of the things that it gave us in terms of increased insurance coverage, increased coverage for individuals, but then we've also got that other thing that we have to look at related to all of the regulations and golly gee, that headache that we're all going to be facing in January related to transparency, that actually goes back to the Affordable Care Act. So let's kind of talk about what this case is all about. What is the issue related to Texas v. California? And what are the likely outcomes? The issue, I'm going to start it in terms of what I want to know. The word that we keep hearing related to this particular hearing that will be on Tuesday involves the issue of severability. And so I would ask somebody, A, pronounce it for me, B, let's explain severability. That was better.
Well, I can try. And the issue is the individual mandate. The federal courts in Texas ruled that the individual mandate was illegal. So the question then becomes, if you do away with that, does that necessarily mean that all of the Affordable Care Act is then found to be illegal? So the issue is severability. Can you just sever out that part of the Affordable Care Act and have the rest of the act remain viable? And I think that's what the issue is going to be. And then the question becomes, because we haven't really seen a different approach from the current administration in supplying coverage. Coverage leads to care. So the question is, if the Affordable Care Act is found by the Supreme Court to now be illegal, what do we do? And that is the more confounding question.
And it gets into the issue of prior authorization. I mean, pre-existing conditions.
Yep.
Because that was one of the major provisions and protections that we got through the Affordable Care Act was pre-existing conditions. So what happens there if it's struck?
Coverage of children up to 26. Medicaid expansion is part of it. So the implications of what the Supreme Court is going to be doing and ruling on are significant. The AHA did a study a few months ago to try to estimate what the impacts would be if, in fact, the Supreme Court ruled against the Affordable Care Act and there was no substitute available. And they're talking about $166 billion loss because of coverage and Medicaid dish reductions, $289 billion loss because the inflation updates would not be available. Medicare, Medicaid dish reductions would be another $103 billion. And they also estimate that the number of insured is going to go up from what it is now, which is about 22 million, to almost 50 million people by 2026.
Uninsured.
Uninsured.
Yeah.
So the implications for hospitals are obviously substantial in terms of what the Supreme Court is going to be deciding on.
The other thing that I would add to Jamie's comments, and Kathy, I think you alluded to it, it's not just sort of the payment, the coverage expansion, the price transparency requirements, but remember within the ACA was all the hospital value-based purchasing. Yep. There was also the Medicare Shared Savings Program and the funding for CMMI. And the other thing that everyone needs to remember is that it also would negatively, if the whole ACA was thrown out, it would also negatively impact the sustainability of the trust fund, not only because of the cuts to the market basket update, but included in the ACA was a pay for that increased the Medicare Part A tax on high income families and individuals. And so you pull that one thread and you've created massive problems across the healthcare system if the whole law were to be found unconstitutional.
And just from the political standpoint, I can tell you, if you talk to what I would call reasonable Republicans, they don't want it to go away. They know that there is no plan, and they have been fighting this since 2010, or battling this since 2010 without a real plan. But privately, I would say, if it did go away, maybe this is that one opportunity, that one moment where both sides say we have an opportunity to fix it. Because if you look at some of the proposals out there, both sides aren't that far apart on a lot of these issues. There are some sticking points there. This might be that opportunity if you, again, have a change in administration and the president really puts, I know he would like to have a legacy here as well on this. I could see there be an opportunity. Again, it would be a long, hard road to get there, but it might give you that moment, because just the facts and figures you all just stated here, that's going to be a hard sell to go back to your community and say, I just put 50 million people out of insurance and things like that.
Well, then, Paul, you just gave me a perfect segue into my question that I had jotted down. Seriously, it's down on paper. I did it earlier. Supreme Court, they have their hearing on Tuesday. We're probably not going to get a decision from them until the spring at some point in terms of their decision on the case. Why doesn't Congress, no matter which administration is in place, why don't we work really, really fast and pass a new bill, get a new piece of legislation out there that takes care of the issue in Texas v. California, but also provides those things that are good in the Affordable Care Act, and get that done. So let this one go away, but here's this replacement that does the same thing.
I believe you could do that. Again, my theory is they have tried to do that in the past, but every time you publicize something, it blows up on the left and the far right and far left. And then you got this whole storm in the media that picks up it. My solution, pick the 5 smartest Republicans in the room, pick 5 of the smartest Democrats in the room, go in there for a week, leave your cell phones out, no staff, come out with a bill. Both of you hold hands and sing Kumbaya. The speaker and majority leader say, yes, this is the plan we're going to pass. If we know people aren't going to like it on one side or the other, but you know what? We're in the middle here, and this is what we're going to do, because this isn't about, and you could get there. For me, it comes down to social media and those types of platforms where it makes it very hard, because you talk to members, they spend half of their days today looking at polls, looking at what people are saying, and that makes it very tough. If you look at history since 2010, there have been proposals that I think in a bipartisan way. Do they accomplish everything? No, but you could get a lot of these things fixed if you just found a few people who had the backbone or the spine to really go out on a limb and buck their party and the electorate.
Thank you. To me, it's just, why don't we just rewrite it and get rid of the things that are causing a problem, but who knows?
Well, and that's why if you look back to 2010 with the ACA, and Republicans had talked about what we would do. There are a lot of what's in the ACA today would end up in a Republican package.
Absolutely. Absolutely.
So you're talking about a handful of items, maybe a little bit more, that you would end up saving the battles for, but you could resolve a lot of these issues. Again, you just need put those 10 people in a room and say, you can't come out until you come out with a deal, no food or nothing.
Well,
and Chad, I'm going to ask you a question because you raised my current pet peeve. I just may as well get it out. You talked about the status of Medicare Trust Fund. And if you look at it graphically, in the mid-90s, where we had just about 5 years left on the life expectancy, if I can use that term, of the Medicare Trust Fund, we got the Balanced Budget Act, affectionately known as BUBA by those of us who had to read all those regulations. Then in 2009, 2010, when we got down to just a few years again, we had the Affordable Care Act that had all kinds of provisions in it that addressed reimbursement and dollars and funding. A lot of programs that were spending was reduced. We now have, as a result of, well, I guess I would say the trustees report that came out in the spring gave us to 2026. It's now been revised to 2024 because of the spending associated with COVID and the um, increased health expenditures and like that. So we're looking at 2024. That I think was in September. And who knows what it's going to be if, as y'all have predicted, we're still going to be dealing with COVID in this, well into next year. Are we going to get another package that takes everything that we know and love away and reduces spending again?
And Kathy, before we address that, let's finish up the conversation on Texas v. California.
Okay. I was looking at it as part. Okay.
Yeah, and they're probably not separate things, but I just want to make sure that we hit a couple of things and don't run off. I guess one is, I think Paul is right. The sensible thing to do would be to put the 5 smartest R's and D's in a room and let them hash it out, and it would be an opportunity to fix some of the flaws in the Affordable Care Act. The other way you could do this is pretty simply, although I don't know how politically palatable it would be. I'm sure probably somewhere in the ruling, maybe if they were to overturn the ACA, the Supreme Court might suggest, or at least give some hints as to what a viable individual mandate is, figure out what that dollar value is, and just put it in at the lowest possible value. And that then takes care of the air quotes constitutional issue with the ACA being a penalty, being a tax. In terms of the actual outcomes, it is, and as Paul rightly said, there are reasonable Republicans and a number of prominent conservative legal scholars who think that this lawsuit is, for lack of a better term, a bunk lawsuit, that it has no basis in merit. So there is one outcome where the Supreme Court could just say, yep, there is the legal theory behind this argument is incorrect. There is no issue here for us to address. Then there is sort of yes, there is a legal issue here with the individual mandate, but and the key term is severability. We're only going to cut out pieces of the law that are directly impacted by the individual mandate, which would be some of the insurance coverage provisions. So clearly problematic, but not everything getting thrown out. And, there is then kind of the most extreme of the whole law goes overboard. So that's kind of the range of things that we're looking at.
Great. Thank you.
Yeah, and I didn't want to leave anybody with the impression that it was sort of a binomial switch of either, Supreme Court upholds it or Supreme Court throws it out.
Great clarification.
In terms of whether we're going to get another Bubba, no one right now is talking about it. And in fact, even physical conservatives over the past 4 years seem to have lost faith, if you will, in kind of in conservative dogma. However, I think once we kind of hit that hard reality that we are T-minus X number of days to trust fund insolvency, I think it will get people's attention. And that was why, as people had talked about what happens if the Democrats would have swept in DC and had Congress and the White House, or the House, Senate, and White House, as people kept talking about public option and expanding the age for Medicare eligibility, the thing that kept ticking in the back of my mind is, yes, but they're going to run into the hard reality of trust fund issues.
There's no money. Right.
Right.
Absolutely. So with that, Anthony, can we open it up to everyone and see what they have to ask about either the trust fund or the Affordable Care Act and its future?
Sure. Any questions, comments, folks? Feel free to unmute yourself and come on my camera if you'd like. Now, if only I had the Jeopardy tune queued up and ready.
That's right.
Nothing in the chat quite yet. So can you repeat the question, Kathy?
Robert, do you have questions? Do you have comments related to either the Affordable Care Act, the hearing before the Supreme Court that's scheduled for Tuesday, or even the future of the trust fund? We kind of merged two topics together then.
Those are two separate questions, Kathy.
I know, I said either.
You can't merge those two topics into one question, though. As somebody who's been around it with healthcare and how with the ACA has its impact, obviously, not only on hospitals, but also on the healthcare system. I just find it hard to believe that it's just going to be, to say it, if it is overturned, that's just going to be a hard stop, right? This country can't stop on a dime like we're like an aircraft carrier. So some of the things may go away, but I think some of the things are going to continue. Now it's just how quickly they come up with. There's got to be another plan on how this is going to function, or else this is going to be a devastation to the entire economy.
Absolutely.
With respect to the trust fund, I mean, I looked at it the other day. I think what was it till
2024 now.
24?
Uh-huh.
And obviously nobody wants to increase their payroll tax. So it's.
Well, then the other option is a 20%, almost 20% reduction in your payments. So.
Yeah, right.
And I'm going to go out on a limb and say that would have a massive impact on both access to physicians and hospital viability.
Absolutely. Absolutely.
Yeah. Hey, we came up with $3 trillion for the CARES Act. Maybe we can come up with some money for the trust fund.
That's happened before, hasn't it? But it was also interesting, your statement, Robert, about we can't just turn on a dime, but aren't we taking it back to COVID? Aren't we going to have to do that when the PHE ends and we have to respond overnight to break up some of the arrangements we've done and things like this in order to be compliant with the real rules as opposed to waivers that are in place?
Right, like a transition period, like telehealth and so forth.
Yes. Yep. Yes. The arrangements we have with physicians and like that. Yes. But other questions or discussion on that issue? Because if not, we'll go to the next polling question.
Cheryl, was that you trying to say something just then? Just want to make sure we give her a chance.
Yeah, I just want to let you know, all I'm seeing is a screen of the Florida chapter in HFMA, and I don't have that chat functionality if I wanted to ask a question. I don't know if it's just me.
So it might be because you're dialed in. Did you click the actual Zoom link?
I'm clicking everything and nothing's happening.
You see the little 3 dots that say more?
I do not have 3 dots that say more. I have 3 dots that say chat, but it doesn't do anything.
Yeah,
which is fine. You don't have to stop everything for us. Right? So for me, I am here. I'm just not responding to the polls because I don't have a means to respond.
Oh, I'm sorry about that. Well,
that's okay.
Feel free to jump in and give us your take, not necessarily through the polling function, but always like your take on things. So appreciate you participating.
Absolutely.
I just hope the Supreme Court uses logic in their decision making.
All right, let's get the next polling question.
Downhill from there. No, I'm only kidding. Okay. Let's go back to our next polling question. This one, polling question number 3, relates to prior authorization. More and more payers, including Medicare, are requiring prior auth for certain services. Has this been a problem for your organization?
I'll answer that. Yes, it's been a huge problem.
Okay, that's your vote on this. So let's have everybody complete the poll. It's been a problem. Definitely. Over the vast majority of you are saying that it has been a problem. So let's just kind of address some questions related to this. We had expansion of prior authorization even under Medicare for hospitals for certain outpatient services last year. We have a proposed rule that further expands that list. We have many payers who are requiring prior auth, but then at the same time, we're getting authorizations we provide services and we get a denial for the service that we provided that was previously authorized. So how extensive is this? What can we do about it? Is there any action on the part of, I throw it to HFMA and AHAM to make requirements on payers that once approved, it should be, the only reason you could deny once there's an approval was if there was falsification of the information given. So let's just see where you are on that particular issue and what you're hearing from your members.
I can go first. I can tell you it's a huge problem or an issue for AHAM members. It is a top priority for us going into 2021. It's been, I say, for the last 4 months, we've been working on a few things here, but obviously a little bit more difficult kind of getting the attention that it needs. But there is legislation out there that's, it's HR 3107. It's called Improving Seniors Timely Access to Care Act. It is very bipartisan. You're talking 262 co-sponsors in the House, 138 Democrats, 124 Republicans. So it has very broad bipartisanship to it. There are some things that we have listed in our recommendations that we want to see it added to it, but this would address some of the problems that you're talking about. And so it's issues like this going forward. I don't see an avenue where you're going to see some big healthcare package pass next year, but I do see an opportunity for some small piecemeal issues like surprise billing and maybe something like this that could possibly pass.
Thanks, Paul. I never thought about including that with a surprise billing legislation, but I think that's a great idea because if it, we have stops on one side, this would be a great thing to include that would kind of be beneficial to the providers or would be beneficial to the providers. Chad, your thoughts?
And certainly it's an issue that we're hearing from our members on as well. And we've got a group of our revenue cycle leaders in a task force, a denials management task force, where a lot of what they're working with is prior auth. And certainly we're working with a number of the payers that are involved in the task force as well to try to address some of these issues at a provider to provider level or a provider to payer level.
Jamie, I'm sure that you're hearing this from your members as well.
We are. I'd like to say it's a new issue, but it isn't. I mean, hospitals have been dealing with this for, 20 years that I have some relationship with them. So I think it's something that we will continue to work out. And it all comes back to money. If we don't have money to pay for stuff, then the conditions that hospitals are going to have to meet in terms of reimbursement are going to get tougher and tougher. Other industries have gone through it, looking at medical necessity issues, and I think it's just our turn. So I think it's something that we will deal with, and I agree with the other panelists. I think it's probably another issue that we're going to see discussed, maybe handled in early 2021.
Before I open it to other folks for their comments on this issue, I don't want to say that I want to expand prior auth, but let me just throw out the concept that we've all been struggling with for the last, I guess I would say 2 years in terms of how to become compliant, particularly for hospitals to report under appropriate use criteria, the requirements for including information on your claims related to a clinical decision support mechanism that the ordering physician would have queried, and whether or not it was determined that that particular advanced imaging test was appropriate or not appropriate, and that hospitals would then have to report that information on their claims for outpatient advanced imaging. Would we be better off to require physicians in a non-emergency situation who are ordering advanced imaging to go through a prior auth process with CMS? Seems like we're asking providers, hospitals to make sure this information is on the script that they get from the ordering physician and to report it, would it be quicker and easier and less burden, at least on the hospitals? The physician already has to query the decision support mechanism. Is there a way to just have them get an authorization and we report an authorization code or something like that? Thoughts? AHAM been looking at this, Paul?
I could check with them. That, to my knowledge, not to that degree, no.
Okay. And Chad, I know HFMA has been involved from a National Uniform Billing Committee perspective in terms of the complexity of getting this information on the bill. But when I've read the rule on appropriate use criteria, it seems to indicate that failure to for if an ordering physician is ordering too many inappropriate tests, that they might then have that ordering physician become subject to prior auth. Maybe it would be easier for everyone involved if they just started off with prior auth, and then if you tend to do a good job, you don't have to continue to do it.
And Kathy, so that I think there is some merit to that approach, both with radiology and also the procedures that CMS finalized in last year's rule and has proposed for this year's rule. That, you know, let's not blanket this on everyone, but let's find the providers that are overusing these procedures or these services, and then let's put some prior auth requirements on them. And, you know, let's target those who have abnormal ordering behavior that is sort of beyond the pale of their peers, and not punish everyone.
Absolutely. I think this is a major systems change for hospitals to have to report this and for the radiologists to have to report it, whereas it ought to be on the ordering physician to provide that information, and not under the current rules, unfortunately, where we would have to report what was the determination on the physician. But that was what I had on prior authorization. Do any of the folks who are listening in, and I would say, I think everyone kind of indicated this is a problem for you, but what kinds of problems are you having from a prior auth? I know we've seen the issues of they give us approvals, but they change their mind. Maybe someone will share what are some of the reasons that the payers are suddenly saying, I know we authorized it, but we are now taking that back. So could we hear from the audience in terms of their issues dealing with this, with prior auth? Okay, don't everyone speak up at once. I see nothing in the chat and I hear no one. Ah, there's Cheryl.
So what's really affected us is wait time now. If we aren't doing something online, to get a hold of someone is very, very long and lengthy, Blue Cross especially. So it's just the length of time it takes to get someone on the phone to even get the authorization if you can't do it electronically.
And you have major payers, it sounds like, who are not set up to do this in an electronic environment.
Or it's in a one-off situation where you have to talk to them because fill in the blank reason.
Got it. Other comments on prior auth? Okay. I think those were our top 3 questions that we had.
We actually have one more. We have one more, Kathy, if you'd like to run.
Okay, I wasn't sure if we had the 4th one or not. Good, because I have a piece of paper here with the 4th one on it.
All right, I got you. Here we go.
Got it.
And share.
Last polling question.
Diane, do we have this one?
No, we do not.
Okay.
So this one is for discussion purposes only.
Okay, so this is the issue related to hospital price transparency, requirement that you comply January 1, 2021, in terms of reporting both through a machine readable file, all the items and services that you provide with 5 different quote unquote standard charges, including your negotiated rates with the payers. And then also have a file of at least, if you provide 300 shoppable services, the 300 services, of which 70 have been identified by CMS. And then as an alternative to that shoppable services, you could have a price estimator tool that does what this whole thing should be about and tells the patient, what are you going to owe? What is your expected out of pocket for the services that you are receiving? In addition to that price transparency rule that everyone's been struggling with for January 1, we kept thinking that this was going to go away based upon litigation. Doesn't seem to be that way now. We have a new requirement for cost reporting periods ending on or after January 1 of 2021 to report by MSDRG your median negotiated rates with Medicare Advantage plans. And then as of last, I believe Thursday, we also now have the new transparency and coverage rule that addresses what insurers are going to have to report and post beginning in 2022 with added requirements in 23 and 24. So I guess I'm going to turn to, I let our panelists decide who wants to go first. Is transparency going away?
I can take a shot if you want. Oh, wait.
Sure.
Okay. This has been a major priority for AHAM this year again. And what we have really focused on is we had sent letters to Congress, and we had talked to several members during the March, April, May timeframe about postponing this or putting a halt to this rule for 18 months because of the pandemic and the stress that hospitals are under. A lot of staff wearing multiple hats more than they normally would, that this was just not something that was going to be able to be done effectively and efficiently. And then if they don't do it, then they're going to be hit with all these fines. There are a lot of members who agree with us on that principle, but they will say the politics is too hot for this, that there's no way that they would put this off. What they did say was that they could see a situation where the penalties are put off for 12 months, or we asked for 18 months. But so those are the new conversations that we are having. We do support the comments the president made earlier this year that said, you know what, the compromise could be that the insurance companies are responsible for handling this for the patients, and where the hospitals are responsible for providing this information, it's on charity care. And for us, that seemed to be, at least for our membership, that seemed to be the fair balance, where when you're talking about price transparency and where you're going to get the true out-of-pocket costs, that's where you're really going to get that, is where the insurers handle the patient's typical patient, and we handle the charity care patients.
Well, it'd be nice to get that resolved between now and December 31st as providers struggle to become compliant.
That's going to be very hard to do, I believe.
Afraid so. Chad?
Yeah, and I would just sort of echo Paul's comments, and kind of that balance of plans are responsible for providing out-of-pocket estimates to their members, and hospitals are responsible for providing out-of-pocket estimates to the uninsured. I mean, that is 100% aligned with HFMA's Price Transparency Task Force report, and that task force included plans providers, consumer advocates, even individuals from, and when I say providers, both hospitals and physician groups. So that's, that seems like the sensible remedy to it. But I think, to Paul's point, there's just not enough time left on the clock, and there are too many other things to accomplish to actually sort of see that break.
Jamie, I know that the American Hospital Association has litigated this. I don't know that they've gotten a lot of positive response from the courts.
They have oral arguments were on October the 15th at the District Court of Appeal in DC. And that's what sort of brings the angst, I think. They're from the perspective of the AHA and the other groups that were part of that challenge. They think there is a good probability that that this rule will be overturned, but given the time that they have to prepare for both eventualities. So while they are still hoping that the District Court of Appeal will find for the AHA, they also have active programs to help hospitals come into compliance with the requirements.
I don't know if folks have seen the actual CMS has actually started paying attention to this issue of transparency, posting some information on their website. The last thing prior to, I think it was around September 30th, prior to that, it was a webinar that they did, or an open door forum type call in December of last year. But now they have posted considerable information on their website in terms of FAQs and things like that. Some things that actually took me back. The requirement that if as a provider you have negotiated a rate with an employer for drug screenings or new employee physicals or things like that, that those have to be reported as well. I don't think that, I mean, to me, it was my payer negotiated contracts was Aetna, Blue Cross, Cigna, et cetera. It wasn't getting into the issue of an individual employer and the fact that I have an arrangement with them to do drug screens. That one kind of surprised me. But the other issue that is out there that was included in their FAQs that I'd love your thoughts on, what in the world is an employed physician or professional?
CMS and the rule left it up just to a choose your own adventure. And it's, you know, normally I am perfectly happy with CMS providing or giving the provider community flexibility to sort of figure these things out on their own. But in this instance, I think probably more specificity would have been beneficial.
Absolutely. I mean, they made this statement. I think a lot of providers early on said, and consultants said that if you have your physician charges as a part of your charge master, I don't know anyone who does have them as a part of their charge master. But then you turn around and now they're saying if it's anywhere within your accounting or billing system, okay, that becomes very concerning in terms of what does that really mean. And I think it's kind of late, September 30th, for CMS to post this.
Right, and I would agree.
There was also the surprise billing executive order from the president that came out September 24th. He addressed transparency again in that and instructed CMS to, within 180 days of the executive order, to post information on Hospital Compare, which is where we tend to go for quality information, as to whether or not a hospital is compliant with pricing transparency rules. That just tells me they're going to be out and looking somewhere beginning January 1. They're going to be very focused in order to, by sometime around March, have it out on Hospital Compare as to whether or not Hospital A is compliant or not. So, I mean, are they going to, maybe as Paul said, are they going to give us a pass on the $300 a day if they're going to be looking that quickly?
I think you also have to look at if there's a new administration, what does that do to executive orders that are in place?
Great point.
I suspect anything healthcare related will try to be undone just because of going back to protecting. And the former vice president was, again, a player with the Affordable Care Act. They're going to try to protect a lot of those things. So I suspect in a lot of different areas, those executive orders that were passed, particularly late in this game, are going to go away.
Isn't there a hold on, I know there's a hold on regulations. Is there a hold on executive orders?
That I don't think so. Again, even on the holds on regulations though, it's for me, I've been around doing this a long time. I have not seen this many regulations in a lot of different areas come out this close to an election. I mean, we have, Department of Labor and some others that have just come out, which they are now in the final rule process side of things that could, if there's a change in administration, that could quickly be undone. So it's just, for me, it's just this administration is just trying to rush a lot of things through.
Good point. Good point.
Hey, Kathy, I don't want to interrupt. I'm sorry, but just give a quick 5-minute warning.
Closing comments?
Well, I think on the price transparency, regardless of who is our next president, I don't think it's going away. If you read the pundits that talk about sort of healthcare from the perspective of the Trump administration, and then what the Biden administration health objectives might be, transparency is on both of those. So it's not an issue that's going to go away. The question is, are we really answering the right question?
Yeah.
And the right question is, as a consumer, I want to know how much it's going to cost me out of my pocket. I don't give a shit, excuse me, about what the negotiation is between the hospital and the health plan, right? I want to know when I go in for care that my bill is going to be within a range of $100 to $200, right? That's what I care about.
Right.
So I think we're focused on the wrong thing. I understand what's going on and the games that are being played and what publishing those rates will do, and it's not going to help hospitals.
And that's what I would just say. I agree with that, Jamie. I think the challenge has been this year and even last year has really been trying to educate members on both sides of the aisle what the real problem is. Because when you hear a constituent who got stuck with, say, some use surprise billing as an example, a $30,000 out-of-pocket cost that they can't afford, then everybody rushes and says, we got to do something about this, and it's the hospital's fault. And then we're going to pass these rules, and you go back to some of the requirements where you just had to put your charge master online. Again, if anybody looked at some of those, I mean, there's just billing codes in a lot of those. A patient's not going to be able to decipher those codes are, so it was really useless. And it's where you got to have the hospitals and the insurance companies coming together, working together, and bearing some of the burden of this. And that's right. The patients want to know what is the bottom line out of my pocket. And that's the hard part. This becomes a politically charged issue and one that I do think is going to be around for a while. But I do think there is going to be a real push, particularly on surprise billing early next year, to kind of get a resolution on that one.
And that's a question that cannot be answered solely by hospitals. It really has to be a joint product between the insurer and the hospital to give the patient, the customer, the information that they're looking for.
Because what we have said to members is, once you do that, you put the onus simply on the hospital. They give you that ballpark figure, and that ballpark figure is not right. Who do you think is going to get blamed at the end of the day? They're going to come back and charge the hospital with not giving them the right, accurate information, which that's the information that we have to go by. It's a wide range. Like I said, a colonoscopy for a 30-year-old is going to be a different cost for somebody at 50 years old, and things like that. So it's a problem, and messaging is, I think, on our side of it, we've got to do a little bit better job of being a little bit more direct and targeted, and I'm hoping that all the groups can collaborate in a more efficient way next year.
I guess I would I completely agree with everything Jamie and Paul have said. I think I would take this a slightly different direction. So if you think about January 1, Kathy, I'm not as worried about somebody from CMS or one of their auditors peeping into my file to see whether my website to see whether I'm compliant or not. I'm worried about the cub reporter who aspires to be the next Tara Bannow or Melanie Evans, right? So I think you need to have good answers to anything that's going to come up from a reporter or for a local community leader to be able to tell your story. The other piece of this also then is, okay, so you're putting your charges out there. At some point, somebody's going to dump these into a tool, and now you're going to be competing with freestanding sites of service for things that are shoppable. Absolutely. That means that you probably need to go back to your contract negotiations and do a rebalancing of how you've negotiated your prices for which you get reimbursed. And there's probably going to need to be a hydraulic where some of the things that are shoppable that the payment for that gets shifted to some of the things that aren't shoppable. And that's just an unintended consequence that we have warned Congress and the administration about, but they have not listened. But, you know, that cross subsidy needs to be there to support the operations of the hospital.
Great, great comments. And I want to thank all of you and Anthony who helped to facilitate the meeting. I really want to thank you for your participation in this. I think there has been a lot of information. Unfortunately, we're only really able to address 4 topics today, but I really do appreciate everyone participating, everyone being a part of the panel, and the great, great comments that you have shared. Jamie Caldwell from the South Florida Hospital and Health Association, Chad Mulvaney from HFMA, and Paul Miller representing AHAM. So thank you everyone for your participation.
Yes, and thank you, Kathy, for leading the charge today. We really appreciate it. Also wanted to give a special shout out to our friends at DeMars for helping us with the logistics, and also a huge shout out to Beth Urton, my partner in crime, in setting these things up, who was instrumental in making all these things happen. So thank you, Beth. Just wanted to give you a special shout out too.
Take care, everyone.
Thank you, Kathy. Have a great day. Thank you, everybody.
Thank you, everyone.